Welcome everybody, and thank you very much, Structural Heart, for the invitation. I was told we had about 40 minutes, so I've really got to get cracking here, so hopefully I can keep you all with me. So I'm going to give you a background about pulmonary hypertension first of all. And I may start with that, just saying that pulmonary hypertension is purely a hemodynamic definition. So it just means that on that day, at that time, the pulmonary pressure is more than or equal to 25. The mean pulmonary artery pressure, thank you, is more than or equal to 25 millimetres mercury. So the first human right heart catheterisation was actually performed by Werner Forssmann in 1929, where he self-catheterised using a urethral catheter into his left antecubital vein to prove to everybody that it could be done, and then imaged that. And he ended up winning a Nobel Prize for that and other things to medical science. I'm going to quickly sneak through this now. So 51, just be aware in pulmonary arterial hypertension, which is a very small subset of everybody with pulmonary hypertension, but these are the ones we really need to be on a lookout for. They have very subtle signs, so they can have fatigue, increased breathlessness, and for someone who's really active, like our patient here, essentially she just noticed that she couldn't quite keep up with what she was doing, and she's very, very physical role, and she had no other past medical history or anything else going on. That's the sort of the list of things that we look at for pulmonary arterial hypertension. Obviously, left heart disease and lung disease and sleep-disordered breathing are the most common contributors. So by the time she comes to see, she's functional class 2 to 3. So on the flat, she could still fly along, but on 2 flights of stairs or a small incline, she picked up that she was a little bit breathless, even though compared with others, you wouldn't have necessarily noticed. There were no other symptoms. And I'll fly through this, but possibly she may have had a loud P2 and she may have had a pansystolic murmur at the left sternal edge, but there was certainly no signs of decompensated right heart failure. I'll fly through this as well, but a basic set of tests are always done initially before they arrive, often before they arrive, to be investigated for pulmonary arterial hypertension. The echo, just know, look, we'd love to have MRI, but obviously echo is what we often have to use. And the RV may have been upper normal in size and may have had low normal function. 1 in 3 people, we can't see a good TR jet, so we can't get a good pulmonary pressure estimate. The pulmonary valve acceleration time may have been a little bit reduced. Normal is greater than 120, but you need to take that into account with all the rest of the echo. Importantly, there wasn't any signs that she had severe diastolic dysfunction, HFpEF, heart failure with preserved ejection fraction, because the E to E prime was normal and the biatrial size was also normal. But the inferior vena cava was upper normal or mildly dilated on the new criteria of 2.2, although the compression looked okay. There's very subtle features, but probably not much going on there. Importantly, no pericardial effusion, because in pulmonary arterial hypertension, that's a poor prognostic sign. Very quickly, don't forget on the chest x-ray, the right ventricle is anterior, so you don't necessarily get the cardiomegaly you see typically with the left ventricle. I've told you about the pulmonary, what is it? Just a hemodynamic definition. But also be aware when we talk about pulmonary hypertension, we're using mean pulmonary artery pressure invasively. On echo, we use obviously the systolic pressure. So an estimated pressure of around 40 is said to mean a mean pulmonary artery pressure of approximately 25. It's really, really important because it's very common. So general pulmonary hypertension, not the PAH, the small subset, but pulmonary hypertension is really common and it's associated with higher risk of death. We know that these patients have poorer morbidity and mortality. It goes unrecognised and eventually you end up with right heart failure, but even those patients with left heart disease associated pulmonary hypertension, you need to focus on their cardiac condition and find out what else you can do to optimise the cardiac condition. So anything within the pulmonary vascular system is going to elevate the pulmonary pressure. I think I need to slow down a fraction here. So if we look at figure B, this is the pre-capillary pulmonary arterial hypertension, that is pulmonary vascular change. So on the left side of the heart, you have normal filling pressure, then you've got change within the capillaries in the lungs, and that increases the right ventricular systolic pressure. C is where you've got left heart disease, so by far the greatest proportion of all patients with pulmonary hypertension have this, where there's elevated left-sided pressure just from heart failure with preserved ejection fraction, valvular disease, ischemic heart disease, long-standing hypertension, all those things. And that increases the pressure within the pulmonary arteries and the right side, but it's all concordant. But sometimes now we're picking up even more patients that are this mixed, combined pre and post capillary hypertension, which they do have elevated left-sided pressures. But on top of that, they've got more chronic change going on in the small capillaries of the lungs, and that's causing a disproportionate increase in the pulmonary pressure. But it's very important to diagnose what's going on because of these, obviously the treatment of vascular-associated pulmonary hypertension is very, very different. Just a reminder, obviously, the pulmonary microcirculation is high capacitance and low resistance, and at rest, we don't actually use most of it. When we exercise, we recruit all these small the microcirculation. The reason I want to bring up the echo very quickly is that if you're receiving an echo report and it does not say, or either it says the pulmonary pressure's 25, whatever, be aware that if you're really truly interested in the breathless patient, unexplained breathlessness, that a normal echo report doesn't mean that they don't have anything going on. It depends on who's reported it and where it's been. We look at that TR jet between the right ventricle and the right atrium, obviously, and we get a velocity, and then that velocity is squared and then times by 4. So a small change in that makes a big difference in the pulmonary pressure estimate. It depends on the day, depends on who does it, depends on the ultrasound beam angle. And a lot of this we can't change, but it's important in the report to then say, is this a clear, good jet or not? Obviously, rhythm can change it as well. And as in Edwina's case, if you've got very large, severe tricuspid regurgitation, you don't get as much of a change in velocity between the two. So you get a lower pressure. However, if you do have a really nice jet, a dense jet that has a good envelope, it does correlate well between pulmonary artery pressure. And that's a reasonable TR jet, but this is often what we see, and you might get a dot here, dot here, dot here, dot up here, and that changes enormously. So sometimes actually seeing the echo images and working it out, whether you can rely on that, how much you can rely on it. This is just other screening tests, but I'm going to rush through this. Right heart cath. So we use a 7 French Swan-Ganz catheter. We blow up. We use this syringe with 1.5 mils of air, and that gets attached to this red part where we blow up a balloon at the tip of the Swan-Ganz, and that's you can see down there in the pulmonary artery. There are a couple of other lumens, and I think again in the interest of time. Pulmonary arterial hypertension is where we have, obviously, the pressure greater than 25 or equal to. We have a low wedge pressure, so there's nothing going on the left side of the heart. And we've got high pulmonary vascular resistance, which I'll talk about briefly. But we know that normal pressure is actually less than 20. And we know that abnormal pressure is greater than 25. So the 21 to 24 patients we have to actually watch very closely. And we're thinking of changing that definition, which comes back from 1970s when they were first sort of diagnosing pulmonary arterial hypertension. So what I do is and we'll see this very briefly later, we place the catheter through the right atrium and the right ventricle up into the PA and then down and wedge it gently. So we have the balloon up, we flow with the blood nice and slowly down into a wedge position. And the reason we then can wedge and get left-sided pressure is that this balloon is occluding the blood behind it essentially. So the transducer is in the tip of the line there, and it's in a column of blood all the way through the lungs onto the veins here, similar size vein, and that's where we're getting a pressure because that's in a column of blood, ideally into a left atrium that's not obstructed. And we get different traces. The traces on the right heart cath are vital to let us know where we are and whether we're getting appropriate measures. The right ventricular trace looks very tall, like a left ventricular trace, although less high. And the right atrial and left, this is the wedge pressure, so it's similar to the right atrial pressure because it's correlating with left atrial pressure. And note the notch in the pulmonary artery pressure. There's some of the things that we look out for. I'll skip through this as well, other than to say we try to use the diastolic pulmonary gradient, which is the difference between the diastolic pulmonary artery pressure and the wedge pressure, to see if that's close, then we think it's more likely to be left heart disease. If there's a big difference there, then it's more likely to be the combined pre and post capillary pulmonary hypertension. In pulmonary arterial hypertension, we use this traffic light system at every assessment of the patients to make sure that we're bringing them up into the left. I know you can't read that there, but sometimes hemodynamics is important, so we can do them over time. It's a very safe procedure, can be done on anticoagulation, and the risk of death, RV perforation or pulmonary artery rupture, is very rare. I won't talk about that today. So why do we perform it with exercise? Well, as I said, rise in resting pulmonary arterial pressure occurs very late in the pathogenesis of pulmonary hypertension. So most of that microcirculation is already gone. So we use exercise to bring out those symptoms and the elevation in pressure earlier. It's particularly important in those with connective tissue disease who have a high proportion of pulmonary arterial hypertension and often go missed, and yet their prognosis is significantly changed if you pick them up early. And also for unmasking pulmonary venous hypertension, especially if you've got that wedge around. We accept less than 15 or up to 15, but really that's probably, you've got to be careful there because there could be some left heart disease. So we want it more like around the 12. So in those patients, they're good to exercise and see what happens to the wedge. So by definition, it's just an abnormal pulmonary hemodynamic response to exercise, but essentially it's an excessive increase in mean pulmonary pressure in relation to the increasing flow. We don't have a lot of information about it yet, and we don't know the natural history of it. So at the moment, we don't include it in our diagnostic guidelines, but there's some thought about that, re-including it. And we use a thing called the total pulmonary resistance, which is just a function of the mean pulmonary pressure over the cardiac output. I'll skip this and go to the case. And there should be sound with it, yes. Sorry. What they're showing... What they're showing here... And really secure this well. And again, try not to move the tissue too. I'll just mute that for a second. So this is fourth intercostal space down the rib cage, halfway between the AP plane. Very, very important to put that in the correct position because that changes all of the values with the right heart cath. And we attach it to the patient, but you don't necessarily have to. I've worked at Vinnie's where you don't. And I might try and fast forward this too. Okay, so here we are sitting up for right heart catheterization. We have a 7 French swan and a 7 French sheath.
Drag that along to where you need to go.
Okay, so essentially 7 French swan gant, 7 French catheter. This is the micropuncture technique, pulling out the wire there. You can see the other wire in the background there. And it's simply like doing a very, very small puncture with a wire, making sure you're in the right place, and then passing your swan gants through that.
Kit. We've just removed this. We're flushing.
It's a lot of flushing.
A lot of flushing. We have the patient who has the head.
But the only thing I do want to say back there, here, note that the patient is very lying up straight with the head rotated to the left.
And tubing running around the back of the head so that the neck is exposed.
But try not to get them to turn their whole body, just a rotation of the head.
Open it up across your face so that you feel you're not too covered. But feel free to close your eyes too.
And with the... Can you see the picture there well on the ultrasound? Fantastic. Use ultrasound guided puncture.
So... There's the IJ, nice and large, easily compressible.
As opposed to the carotid.
Between the carotid and otherwise.
You don't want to hit.
This will sting a tiny little bit.
It's interesting when you use ultrasound, the variance in anatomy. In the past, we didn't use ultrasound. We sort of dug around.
Whenever you're advancing, always pull back.
So I'm advancing slowly, but with pressure pulling back.
You don't inject into the vessels. So we've got the micropuncture kit. The small needle here.
The needle.
You might feel some pressure here, but
go
no
at about
pain.
45 degrees, 30 to 45 there. It's a very large IJ there.
So again, gently advancing. You can see in there, you can see the needle just above. And now I pull back. Slowly advance, and then that's got the access. So guys, can you grab the ultrasound for me, please? very gently advance the wire.
And we essentially pass the wire through. Once we know that that's in
Easily.
position, we pull the needle out. Do you need me to speed up through this? So, placement. Now, so you can see it up there. Note, I was actually having trouble here. So it was coming out and not going straight down the IJ. So I had to sort of pull back a little. Oops, sorry. With the sheath and then pass through. You see it passing down there into the right atrium. And I can tell it's nicely in there. So then I'm happy. I image that, not everyone does. I'm happy with the wire before I want to put in the sheath.
Fluoroscopy in the right atrium.
Now,
Is we're just shifting. Thanks, guys.
we have a bar
Shifting the
that's
collar
been...
around to the top of the head without pulling too much on the drape, because remembering it's attached to the patient here. That's wonderful. Now that's going to take all our support. Thank you, Sarah.
So we just had a bar that we used there that was open the patient underneath the cover, so they're not...
cardiac output. It's coming from here. Thank you, Sally. Yes, fine.
You can see where the cardiac output comes out through there.
Nice and hard and firmly.
So down here, so once that's in the heart, it'll come out in the right atrium and pass with the blood past the tip of the catheter.
We will do the same to the distal lumen. There we are.
And it's the temperature change in that
Nice
helps
and
us
long.
work
Keep
out,
going,
that gives
keep
us the
going,
cardiac
keep going.
output.
Okay, that's fantastic. So we're now ready to zero.
We zero, so it's very important to zero the whole way through the
You can
case.
see it in the right atrium there, and always blow up atrial pressure.
Never
Right
advance
atrial pressure
really
there.
without the balloon
We get
blown up.
the scene here.
And you can see the right atrial trace
Okay, it
here.
looks like a nice pressure
A and
trace.
V waves consistent with atrial and ventricular
And that
contraction.
looks quite reasonable, right?
RA
We'll just
average of
try and
6.
pass through. If you can chase
Now we're
the
passing
movement
down from the right atrium,
directly
right ventricle, and gently up into the
too far.
pulmonary artery,
Take you back again.
which is normally quite easy to do
The
because
other
that's the way the
thank
Swan
you.
Gantz
And
is
we try to actually go straight
designed.
to a wedge, if
And look
that's
at the trace
possible.
here.
Just optimising that trace. So I've decreased the balloon.
It's come down
tiny
into a wedge, but
fraction.
not a very
You
nice
can
wedge.
see a tiny bit of whip in the lead at times there in the trace. I
Right, just
really would like to see slightly.
And so I'm trying gently to lower the balloon just a fraction to enable it to wedge a little better and make the trace look better, because the whole diagnosis is dependent on the look of that trace and what the wedge pressure is. It's very important.
And just see if that helps it slot into wedge position. That looks nicer.
Now we know the wedge, look, it's getting very low values, but I still wanted to just optimise the look of the wedge. So there's no question that this is left heart because the wedge is low. And that's a respiratory variation
A
there.
little bit of pressure. That looks like a really good trace. It's very
So I'll keep going. There's pulmonary artery trace here
tiny little bit of flick
with a
there,
notch
but otherwise we can see
coming
the
through, and we're getting a
nice
PA pressure of 20 in this
PA
case.
trace. We grab 3 recordings from there.
And we always get 3 recordings, and we also get 3 cardiac
We'll
outputs
grab
within
3
10%.
pulmonary artery pressures here, and if you don't mind setting.
So we'll set up, we do cardiac outputs, I'll skip that in the interest of time, but we do it this way, so from this side, the left side of the bed.
I often talk to the
You want to
patients
see a
about
nice,
the season,
steep,
it's important not to
good
talk to
trace here coming in
cardiac
quickly
outputs.
and get 3 within
Can
10%
change
to make sure it's as accurate as it can be. And then I'll just quickly go to the bike. Okay, here we are attaching to the bike. And we essentially just have some bike pedals that the patient exercises for ideally 7 minutes, try and get to 85% of target predicted heart rate, and try and get a good blood pressure response. And then we quickly race around, lower the legs, lie them flat, and then quickly grab all those pressures again to see what the immediate post-exercise pressure is, so cardiac output as well, so that we can work out all those values. I think that's it. It's very important at the end of the case to take out the tubing on expiration. I won't show you anymore. I'll just quickly, can I interpret some right heart caths? Okay. And then we get a venous gas, as well, just to check that. So let's interpret DS, patient. So she had a mean pulmonary pressure of 36. So 25 is abnormal, so clearly abnormal. Her wedge was nice and low, 11. Then we work out the transpulmonary gradient. You see that often, which is just the difference between the left-sided pressure and the right-sided pressure that we're getting across the lungs, and that's 25. So less than 12 is normal, so this is clearly abnormal. Lowish, reasonable cardiac output, but on the low side there. And then we can work out a pulmonary vascular resistance, which is the transpulmonary gradient divided by the cardiac output. So that's why it's vital to get all of these values correctly, because the mistake carries the whole way through. So Wood units of 3 or greater is abnormal, and 2 or less is normal. So this patient has idiopathic pulmonary arterial hypertension. With exercise, so let's take another patient. Mean pulmonary pressure 18, that's all normal. Normal on the left-hand side, transpulmonary gradient's normal, and the vascular resistance is not quite normal, that's less than 2, but it's not abnormal, which is greater than 3. With exercise, this patient's pulmonary artery pressure goes to 34, so anything above 30 could be abnormal, or is probably most likely. The wedge stays quite nice and low, but the transpulmonary gradient, therefore, the difference between the two becomes quite high. Cardiac output goes up. And then the pulmonary vascular resistance, which is just that transpulmonary gradient divided by cardiac output, then becomes 2.9, remembering 2 is normal, 3 is abnormal in a rested state. Then if we actually work out the total pulmonary resistance, which is a function of the mean pulmonary artery pressure and cardiac output, that comparison, we get that's actually elevated more than 3. So it looks as though this patient has exercise pulmonary hypertension. Not that we know what to do with these patients yet, and we don't have the evidence, but we're getting more and more information. Certainly we need to follow these patients very closely. And I'll just show you a case for left heart disease. So mean pulmonary pressure of 22, so in the grey zone between 20 and 24. Wedge just holding in there, could be normal, but might not be, depends on their fasted state. Transpulmonary gradient is therefore normal, just the difference, and reasonable cardiac output, and the pulmonary vascular resistance therefore is normal, under 2. With exercise, the pressure goes up, not too high though, but the wedge pressure goes to 17, so it's left heart. So transpulmonary gradient then becomes upper end normal, and if we work out the pulmonary vascular resistance, it's still low. So that's saying that it's left heart disease causing her symptoms of breathlessness. So I hope I've answered some questions in that time.
Very good, well done.